Good morning, Dr. Isa. Good morning, Atsa. Good morning, Manimaran. Good. Okay, right. Thank you. So, it is 8:30. I think almost all have joined. I think, yeah. So what we will do is we will do a quick recap of whatever we studied yesterday, right? So that can also be an active recall, right? For I like we studied in memory, when there is a recurrent recall, the brain activates a search and find model. So when there is a search and find, your neural connections are strengthened and your long term consolidation is higher, and it becomes a very good explicit long term memory, right? So the first chapter that we studied yesterday was doctor patient relationship, where it is a very important therapeutic relationship which has also therapeutic benefits. The patient comes for a good follow up if there is a good rapport, confidentiality, privacy is all to be maintained. What are the good aspects of communication, the verbal and non-verbal and the paraverbal aspects that we discussed? And the most important thing of communication is breaking bad news, for which we use this spikes protocol, where the setting should be appropriate, the person's perspective should be taken into account, the information required, the knowledge required, and the emotions should be addressed with empathy, and then it should be summarized and strategized regarding the future treatment plans. So this is the most important part of this chapter. Along with that, we saw what mental health means as a model for normality. So mental health as above average, mental health as increases with age, with positive emotions, with socio-economic intelligence, and a sense of general well-being, and also using defense mechanisms, where we if you use mature defense mechanisms, you have a better mental health. So we also studied a little about defense mechanisms, what is transference, countertransference, etc. Then we went into the chapter on mental health, where we defined what mental health is and what is the biopsychosocial model of mental health given by George Engel. What are the biological factors, psychological factors, and the social factors that can precipitate or predispose somebody to get a mental illness? Then we saw what stresses, what good stresses, what bad stresses. We saw the Yerkes Dodson model, where there needs to be an optimal stress for optimal performance. Then we saw what personality is, what are the five factors of personality. Then we saw what memory is, memory, what is encoding, storage and retrieval, what is working memory, what is recent memory, remote memory, what is immediate memory, how do we test all these memory, what is Ribot's law. Then we saw what emotions are, what an intense emotions requires, all of what are the components, and then what are the other personality theories given by various scientists, and what Maslow's hierarchy of needs is, where the basic physiological needs has to be met, then the safety needs, then love and esteem needs, then the self-esteem needs, and then only self-actualization can occur. And then we saw a little on what motivation is also, right? So that concludes the chapter on mental health. Then we went into introduction to psychiatry, which is an important topic, where we studied what are the nuances in taking psychiatric history and what mental status examination actually means. In mental status examination is a specific examination of a psychiatric patient, where we look at the general appearance and behavior, we look at how their eye contact is, what their attitude is, how their dressing is, do they have any tremors, is there any motor movements that is there accompanying them. Then we saw what mood is, what speech is, and how to assess the speech, the quantum, what is tone, what is the rate of speech, and it is increased in mania, decreased in depression, and negative symptoms of schizophrenia. Then what mood and affect is, mood is the longitudinal inner subjective feeling experienced by the patient, affect is the cross sectional outer objective expressions as observed by the examiner, how mood and affect are congruent and how they are appropriate, what is the quality, what is prosody, what is lability, etc. we studied. Then we went into disorders of thought. In disorders of thought, we studied there are four types of thought disorders: disorders of form, disorders of stream, disorders of thought content, and disorders of thought position. In disorders of form of thought, the structure or organization of the thought is lost. So there is loosening of association, tangentiality, derailment, neologisms, and then voiberdine. In disorders of stream of thought, we saw that the speed and continuity can be affected. When the speed is affected and the speed is increased, it is seen in flight of ideas and prolixity, as seen in mania and hypomania respectively. And when the speed is decreased, it is seen in thought retardation and thought retardation and circumstantiality. Then we saw what is the disorders of thought continuity, thought perseveration, where a thought exists beyond the point of relevance, and then thought block, where a train of thought is blocked and another train of thought starts after a period of pause. Then we saw what is the disorders of thought content, that is delusion. Delusion is a false fixed belief held with extraordinary conviction which is out of keeping with the patient's social, cultural, and educational beliefs. There are various types of delusions like delusion of persecution, delusion of reference, delusion of jealousy, delusion of love, delusion of pregnancy, delusion of nihilism, delusion of grandiosity, delusional misidentification. In delusional misidentification, we specifically saw what Capgras syndrome is and what Fregoli syndrome is. In Capgras syndrome, the person is look like a close person but is a stranger disguised as a close person. In Fregoli syndrome, the person looks like a stranger but is a known enemy disguised as a stranger, right? So after that, we saw disorders of thought possession. There is patient realizes it's one's own thought, but the thought occurs recurrently and they are not able to control it, as seen in obsession. And the patient thinks that their thoughts are being controlled by some alien feature, that is thought alienation, which includes thought broadcasting, that everybody can hear their thoughts, thought insertion, that somebody is inserting thoughts into their brain, and thought withdrawal, that somebody is removing thoughts from their brain. So these are the disorders of thought. Then we went into perceptual disorders, mainly which is hallucination. So there is a perception without a stimulus, that is called as hallucination. When it occurs in the visual modality, it is visual hallucination, more commonly seen in organic psychiatric disorders like delirium and in dementia. In dementia, Lewy body dementia has higher propensity, but it is also seen in Parkinson's dementia and then on other dementias. Whereas auditory hallucination is seen more commonly in schizophrenia and then in other psychotic conditions. The gustatory and olfactory hallucinations are very rare, but it is seen in schizophrenia. Tactile hallucinations are also seen in multiple conditions, delusional parasitosis, schizophrenia, etc. But it is most commonly seen in cocaine abusers, where it is also called as Magnan syndrome, formication, or cocaine bugs, right? Then we went into higher mental functions, where the consciousness, orientation, attention, concentration, etc. are tested, and there we specifically saw what is abstraction. For abstract testing, we use similarities and differences and proverbs. Then we saw what insight is. Insight is one's awareness of one's own illness. There are various grades of insight. And then judgment. Judgment is the ability to decide based on the information provided to them. There is test judgment, personal judgment, and social judgment, right? Based on this, we come to a diagnosis. Diagnosis is given based on International Classification of Diseases 11th edition, that is ICD 11 given by WHO, or Diagnostic and Statistical Manual 5th edition DSM 5 given by American Psychiatric Association, right? Other than that, we saw how psychiatric disorders are classified into organic psychiatric disorders and functional disorders. Functional disorders classified into neurotic illnesses and psychotic illnesses, and then we went into each illness in detail. So first illness we studied was organic psychiatric illnesses, that is neurocognitive disorders, delirium and dementia. Delirium is an acute onset of confusion, disorientation, and fluctuating orientation that is accompanied by other cognitive problems like delusions, hallucinations, and other attention difficulties. So it is occurring in the setting of mostly of a medical or a surgical illness, and it is precipitated by infections. So for delirium, we have to identify the cause and treat it. One rating scale that we can use is MMSE, or confusion assessment method. EEG can also be used where there is a diffuse slowing of cortical waves, except in delirium tremens where there is an increased activity, right? So for treatment of delirium, we identify the cause and treat it, but supportively we can give low dose antipsychotics which do not have an anticholinergic action, and also we can give benzodiazepines. Right. So the next was dementia. Dementia is a chronic progressive cognitive decline. So in that, multiple domains are affected. That is the social cognition, the complex attention, the memory, the perceptual motor functions, and the executive functions. All of this, there one or two are affected for a period of more than 6 months. Right. What happens in types of dementia? There are reversible and irreversible dementia. Reversible dementias, a cause can be identified and treated, like normal pressure hydrocephalus, subdural hematoma, deficiencies of vitamin B12, folate, or thiamine, and then in hypo or hypoparathyroidism, and such trauma and alcohol and other toxins. Irreversible causes of dementia are all the neurodegenerative dementias like Alzheimer's, frontotemporal dementia, Prions disease, Huntington's disease, Parkinson's disease, Creutzfeldt-Jakob disease, all of that. Right. Based on the site of lesion, there are cortical dementias and subcortical dementias. Cortical dementia, site of the lesion is in the cortex. Subcortical dementia, it is in the subcortical gray matter like the basal ganglia and hypothalamic nuclei. Right. So for cortical dementia, example is Alzheimer's dementia and frontotemporal dementia. Subcortical dementia examples is Huntington's dementia, Parkinson's dementia, and Wilson's disease dementia, etc. Right. Based on the pathology, Alzheimer's disease have the actin deposits, neurofibrillary tangles, and Hirano bodies, etc. And the most common type of dementia is Alzheimer's dementia. Most common early onset type of dementia is also Alzheimer's dementia, but the second most common early onset dementia is frontotemporal dementia. In frontotemporal dementia, you have a behavioral variant and a language variant, and vascular dementia, there is a step ladder pattern. Lewy body dementia, there is Lewy bodies predominantly. There is a fluctuation and there is motor symptoms and cognitive symptoms occurring simultaneously, right? And in dementia pugilistica is also called as punch drunk syndrome. For dementia, there is no definitive management for irreversible dementia, but we can use acetylcholinesterase inhibitors like donepezil, rivastigmine, galantamine, and also NMDA antagonists like memantine and lecanemab, aducanumab, etc. Brexpiprazole is approved for agitation in Alzheimer's dementia. Right, so that is the end of neurocognitive disorders. Then we saw substance use and addictive disorders. What is the criteria for addiction? There is needs to be increased craving, tolerance, withdrawal symptoms, narrowing of repertoire. That is neglecting alternative pleasures and only seeking this particular substance for pleasure, and use despite harm, and not able to control the substance seeking behavior. Right. Alcohol, we saw what are the symptoms of alcohol, what are the blood alcohol concentration corresponding to the physiological symptoms, and what are the types of alcoholism by type 1 and type 2 by Cloninger, what are the withdrawal symptoms, what happens in 6 to 8 hours, tremors, and then alcoholic hallucinosis, then seizures, and then delirium tremens can occur, and what is Wernicke's encephalopathy, what are the GOA symptoms, global confusion, ophthalmoplegia, and ataxia, what is Korsakoff psychosis, what is the treatment for them, and then what is the treatment for alcohol detoxification, withdrawal symptoms, benzodiazepines is the treatment of choice, and for maintenance we use a lot of anti-craving agents, camproset, naltrexone, baclofen, SSRIs, ondansetron, etc. And then there is a deterrent agent called disulfiram. Then we saw what is opioids, opioid intoxication, we give IV naloxone. Opioid withdrawal, we have to treat them with buprenorphine, methadone, and for maintenance also there is opioid substitution therapy where there is buprenorphine, naloxone. For anti-craving property, we can use naltrexone. Right. And then cannabis has various forms, and it can cause a flashback phenomenon, bad trip, etc. And it can cause amotivational syndrome. Then we saw what are the various hallucinogens, then what are the various inhalants, and then what is stimulants for cocaine, cocaine bugs, and it causes a blackish discoloration of tongue, nasal septal perforation, etc. And then nicotine we saw what can be done for it. The nicotine replacement therapies, gums, lozenges, patches, nasal spray, and oral inhalers. And then varenicline and bupropion. Varenicline is alpha 4 beta 2 partial agonist, and it has a black box warning of suicide and stroke. And bupropion is an NDRA, it's an antidepressant with less sexual side effects, and it has a very good anti-craving property in smoking. Right, and then we saw some other minor medications which can be abused also. Right. Then we went into schizophrenia and related psychosis. So what is schizophrenia? Who gave the 4 A's of schizophrenia? Eugene Bleuler gave the 4 A's of schizophrenia and coined the term schizophrenia: autism, ambivalence, association, loosening, and affective flattening. And then we saw what are the first rank symptoms of schizophrenia? First three: hallucination, first person, second person, third person. Second three: thought alienation, thought broadcasting, insertion and withdrawal. Third three: made phenomenon, made feelings, acts and impulses. And then somatic passivity and delusional perception. And then we saw what are the positive symptoms: delusions and hallucinations. Negative symptoms: alogia, anhedonia, um, affective flattening, etc. And then we saw what are the disorganized symptoms. Disorganized speech is formal thought disorders. Disorganized behavior is catatonic behaviors. In catatonia we saw what is mutism, catalepsy, abnormal posturing, grimacing, echolalia, echopraxia, negativism, automatic obedience, mannerism, stereotypy, grimacing, etc. For catatonia, IV lorazepam is the treatment, and then you can give ECT. Right after that, hmm, we saw what are the criteria: delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms. There should be two, and one should be from the first three for a period of 6 months. Treatment you can do using antipsychotics. There are first generation antipsychotics, there are second generation antipsychotics, and then you can go for long acting injectables for patients with poor compliance. We can go for ECT. We can go for psychosocial rehabilitation, where we address the expressed emotions and give social skills training. And then we saw other psychotic disorders where then the duration criteria is not met, like in acute psychosis, brief psychotic disorder, schizophreniform disorder. And then we saw delusional disorders can occur alone, and then there is shared psychosis: folia due, folia familiae, prop schizophrenia, Van Gogh syndrome. And then we saw schizoaffective disorder also. Then we went into the mood disorder spectrum. In mood disorder there is depression and bipolar affective disorder. We saw what is MDD, what is recurrent depressive disorder, what are the symptoms of it. And then we saw what is bipolar type 1, what is the bipolar type 2, what is cyclothymia, what is dysthymia, etc. In major depressive disorder we studied the criteria using the mnemonic called as siege caps, that is sad mood, interest decreased, feeling guilty, uh, energy decreased, concentration decreased, appetite decreased or increased, psychomotor activity decreased or increased, and then sleep decreased or increased, and suicidal thoughts and urges. So out of this, the 9, there should be 5 and 1 should be from the first 2, and for a period of 2 weeks. Right, recurrent depression can occur anytime but after a period of 2 months. Right. Then we saw what are the specifiers like atypical features, what is psychotic symptoms, and then peripartum onset, what is postpartum blues, postpartum depression, and postpartum psychosis. We studied 2 new drugs there: brexanolone, zuranolone, and we can also give SSRI, CBT, and ECT if required. Right, and then we saw what are the physical manifestations of depression, while there is very good fold, omega sign, etc. And then we saw the drugs used for depression, the antidepressants that we saw. Right, then bipolar affective disorder type 1, there is mania plus or minus depression. Type 2, depression plus hypomania. And there are other types that's discovered by Akiskal, but these two are the recognized by the classification. Right, for bipolar depression we need to have a high index of suspicion, because antidepressants can precipitate mania. So if there is a psychomotor retardation or severity of symptoms or sudden onset of depression or increased response to medications or suicidal thoughts or psychotic symptoms or a family history, then it is a high index for bipolarity. And then we saw cyclothymia, where the criteria for mania or depression are never met, but it has ups and downs for a period of 2 weeks. And then rapid cycling disorder, more than 4 episodes of mania, depression, or mixed features for a period of 1 year, and more than 4 episodes in 1 month is ultra rapid cycling. Right, so with that we come to the conclusion of bipolar disorders. For treatment we use lamotrigine, lithium, sodium valproate, carbamazepine, etc. And then we also saw a little about the psychiatric emergencies, that is a chapter 17. What is suicide, what is the rate of suicide, what is Werther effect, what is paradoxical suicide, what is deliberate self-harm, how to handle a violent patients. First we have to address their medical concerns and then look for the medication adjustment, then we can do a verbal de-escalation and timeout, and then then try oral medications, and then try IM medications, and then try IV medications. And what are the other medical causes that can precipitate a violent behavior, like delirium, head injury, and encephalitis, etc., right? So that is it. We have recalled everything that we studied yesterday. Shall we go into the topic? Do you have any doubts? I'll wait for a minute. If you have doubts, please ask. Right. So PDF not shared. Yeah, that PDF I will send it to you. The people here will come after, I think, 9 o'clock or something. So before I take those particular chapters, I will send you the PDF by the first break probably. Yes. So let's go into the first topic of anxiety disorders. Right. So anxiety disorders. I'll just ask you a quick question. Do you think anxiety is normal or abnormal? Okay, majority of Uh, thank you, Dr. Atsad. Thank you, Dr. Manimaran, for a very specific answer. But majority of the answer is normal. So if you think it is normal, then why are we having anxiety disorders as a chapter in psychiatry? Right. So anxiety, once the stress are removed, turns to normal. Okay. So anxiety is, like, for example, you are preparing for NEET-PG. Tomorrow is the exam. Won't you feel anxious today? Tomorrow is your viva. Don't you feel anxious today? So you're going to perform on stage. Maybe you're playing guitar or something. Won't you feel a little anxious, right? And maybe you are going to express your love to your loved one, or you're going to express your relationship to your parents, to the partner's parents, let's say. So all of these situations provide anxiety. So why is this anxiety there? Why is it normal? So in evolution, if you see, the survival of the fittest is the reason for evolution, right? So when the evolution was for animals, or when the human beings were hunter gatherers, what was essential was survival, right? So in order to survive, you should you should escape from a predator, right? If somebody is going to come and eat you, let's say you're a rat or a rabbit, and a lion is going to come and eat you, you have to escape. Only then your chances of survival will increase. And if you are a predator, if you are a lion, you have to catch the prey, because your livelihood, your health depends on it, because without food you are going to die. So for both the predator and the prey, there needs to be some sort of reactions in their body so that they can survive. So for that, anxiety was very useful for prey to escape from the predator. The anxiety was very useful for the predator to actually be very cautious and catch a prey. Again, then anxiety was very useful. That is what we study in our sympathetic overactivity, right? The fight, flight, and fright reaction also. It's both fight, flight, and fright. All three requires the sympathetic overactivity, and that always produces some sort of anxiety, right? So and what happened was, this brain, the animal brain, actually persists in us, which is the limbic system, and that is responsible for our emotions. So what was a protective mechanism before, it is still a protective mechanism, because you need to have a little sense of anxiety. If you are not anxious that somebody will steal your things, you will not close your door and go, right? And if you're not very anxious that something bad will happen, or if you're not anxious that a snake might come into your house, you wouldn't take care of it, right? So some sort of anxiety is again protective in a lot of nature. But what has happened was, the perceived fear for not real threats also. And when this perceived fear or anxiety persists irrespective of the situation, so you're seeing a snake and you are getting anxious, that is normal, the normal fear, normal anxiety. If you think that there might be a snake and you're getting fear, that is also to an extent might be okay. But if you feel that every time you go through the situation, every time you're sitting inside the house, oh my god, there might be a snake here, there might be a snake here, there might be a snake here. So if you have that persistent fear, So I'm just giving you that example of a snake, but if you're having that persistent fear, then that becomes a problem, because if your body is in fight or flight mode all the time, your BP is going to rise, your sugar levels are going to rise, your cortisol is going to do a lot of things to your physiological status, and ultimately you might end up getting other psychiatric symptoms also. So this is a problem, right? That is why it is a disorder, right? So it is normal, but when it becomes persistent, pervasive, and impairing our functions of day to day life, it becomes abnormal. So let's say anxiety is an intense, excessive, and persistent worry and fear. Okay, so the entire chapter we are going to study with this one table itself. This intense, excessive, persistent worry and fear, which is called as anxiety, if it occurs, if it occurs during unpredictable situations of time, right, it might be under panic disorder. If it occurs in specific situations or time, it could be either a specific phobia, agoraphobia, or social anxiety. If it is going to occur all the time, everywhere, it is called generalized anxiety disorder. So this entire chapter is summed up in this. So this intense, excessive, persistent worry and fear might or might not be associated with panic attacks. This panic attacks is a specific thing. Let's say panic attack is kind of an intense fear that is occurring for few minutes, like 5 to 20 minutes, and it rises in intensity and comes down. That is a commodore decommodore pattern, and it is associated with a fear of impending doom, that I might die, I might get a heart attack or something like that, right? So this is a panic attack, and it mimics in a lot of medical conditions also. So if this occurs, unpredictably all the time, just like that, I'm walking and I'm suddenly having a panic attack, I'm walking, I'm suddenly having an anxiety attack, then it could be a panic disorder. Like if it is occurring whenever I go to a marriage function or some sort of college get together, or even going to a regular class, I'm not able to sit there, or when I'm going to go through a crowded bus, I'm not able to uh, you know be comfortable, then that could be social anxiety. Or if it is where a situation where I am not able to escape, that if that is the point, then it could be agoraphobia. Or if it is specific, like a fear of cats, or fear of dogs, or fear of snakes, etc., then it could be a specific phobia. Now this is occurring like all the time, so all the time anxious. Okay, waking up I'm anxious, if it is an OPD day I'm anxious, if it is a free day also I'm anxious. What if somebody comes in, what if this happens, what if this happens? So there is a worriness every time, then it is called as generalized anxiety disorder. If you think about it, we would know at least one or two people in our friend circle or our families with generalized anxiety or some sort of anxiety all the time, right? So it is very common, and it is not until it becomes a problem to them, their physical health or their mental health or their quality of life, they do not come for treatment. But this is prevalent everywhere, right? So just we'll have a quick look at the duration criteria for all of this. So the duration criteria, because it's easy to learn it together, for panic disorder is 1 month, whereas for others it is 6 months. And the epidemiological thing also is a little easy if you learn it together. For all anxiety disorders, females are more than males, except social phobia, or social anxiety where female incidence is equal to males, right? So what are the peripheral manifestations of anxiety? So whatever sympathetic activity will do to the body, everything can happen when somebody is anxious, like diarrhea, dizziness, lightheadedness, hyperhidrosis, that is excessive sweating, palpitations, pupillary mydriasis, restlessness, syncope, tachycardia. This one was asked in INI-CET 2024. If some of you all attended yesterday's test and discussion session, in which there was this question also, right? So it could be all of these are peripheral manifestations of anxiety, right? You should know it, right? So what happens in a panic disorder is recurrent, unpredictable panic attacks, right? So what is a panic attack then? Panic attack is a sudden onset of intense anxiety. This intense anxiety can be palpitations, whatever peripheral manifestation it could be. It could be palpitations, it could be sweating, it could be shortness of breath. It could even sometimes be like vomiting, or it could be just a syncopal attack, whatever, right? It could be anything which is accompanied with fear of impending doom, that is fear of dying, and it lasts for 20 to 30 minutes. Usually it settles on its own when you leave it for like 20 to 30 minutes. It will settle on its own. Sometimes it even lasts for only like 2 or 3 minutes, and then you get better in 10 to 15 minutes, right? So the neurotransmitters involved are norepinephrine, serotonin, GABA, and cholecystokinin. All of these neurotransmitters are involved in panic attack, right? So okay, so today you've all studied panic attack, and maybe some of you are all working, or some of you all might have seen. Okay, so today I've studied panic attack. So a person who's coming with an intense pain, palpitations, and tremors to your OPD or your casualty, would you just diagnose them as panic attack? No, because everything that is serious also mimics this, right? It could be an MI, it could be an angina, it could be an acute asthma attack. So we have to look at the other differential diagnosis of panic attack also. So it could be an MI, it could be angina, it could be arrhythmia, it could be embolus, it could be asthma, it could be a hyperthyroid state, it could be hypoglycemia. Simply patient will come with palpitations and stress, right? In pheochromocytoma, there is excessive sympathetic overactivity, there is hypoparathyroidism, then there is transient ischemic attack, even some seizures present in this way. So we should be very, very cautious before diagnosing something as panic attack. We have to rule out every possible medical cause, and then only we can call it as a psychological cause, that is panic attack. Okay, you have done ECG, you have auscultated the patient, you have done everything, and you're sure that it is a panic attack. Then what will you do for an acute attack? You give them a benzodiazepine. So there are clonazepam mouth dissolving tablets. um There are short acting lorazepam, there is mouth dissolving, and there are sometimes even alprazolam works. So we give short acting, quick acting benzodiazepines. right? But it is occurring again and again. It has become a panic disorder. It's not just an isolated panic attack. See, isolated panic attack can occur for anybody. Once in a while it is occurring. It has occurred for you in your entire 20-25 years of life. It has occurred only once. Then it is not a panic disorder. But in a period of 1 month, it has occurred for more than 4 or 5 times, right? And it is unpredictable and it is occurring again and again, then it is a concern of a panic disorder. So then you have to take a pharmacotherapy, that is SSRI plus or minus benzodiazepine, and for psychotherapy we use cognitive behavior therapy, CBT. Okay, so the treatment of panic disorder is both CBT plus SSRI, right? So basically, it requires every anxiety spectrum disorder. We use therapy as an important part, because it's not going to go away just with, because when we stop medicines, it might come back again, right? So we have to give them cognitive behavior therapy, help them how to identify these negative thought patterns, and then get better. Right. Now coming to situational anxiety. So like I told you, this panic attack can occur anytime. And whenever you're very anxious about certain things, it will occur. So it is occurring unpredictably is what we saw in panic disorder. But when it occurs along with other anxiety symptoms in such situations of where you are not able to escape, right? So public transportation, open space, enclosed space, or alone outside of the home, you're not able to escape, right? That is the key thing. So if you're in a public transport, you cannot suddenly stop and get down. From a train, you cannot jump, right? When it's an open space and there is nobody around you, again you cannot escape. When there's an enclosed space and there is no easy exit, or in a crowd, or when you're standing in a line and you're not able to go, so when you feel that cramped and you're not able to escape, or when you're going alone and something happens, and then that kind of fear. So what has happened is, what will actually happen, the most common comorbidity with agoraphobia is panic disorder. So what actually happens, this it almost always occurs together. So you've suddenly started getting panic attacks, and these panic attacks have been occurring in an unpredictable way. Panic attacks, even though it is just psychological, it is going to have a very huge impact on you. It is like each time you get that, you feel like you're dying. Imagine the impact it has on your mental health. So whenever that is happening, you will have an extensive fear, and because of that extensive fear, you will okay, what if a panic attack comes here, what if that panic attacks comes here, so you will start avoiding places, and you will start avoiding places where you are alone, right? Alone outside of the home, or in an enclosed space, or in a crowd. So what if somebody cannot help you? When there is a known person, they will help you. There is nobody to help you, what will happen if I die? That kind of anxiety is what entirely makes you fearful of situations, not able to escape, and then precipitates agoraphobia. So the diagnostic criteria is that you need to have marked anxiety from two or more of the following five sittings, that is public transportation, open space, enclosed space, in a crowd or standing line, alone outside of home. Okay, so what happens in social anxiety disorder or social phobia? So there is fear of social situations, including situations that require scrutiny or contact with strangers. Like I told you, it could be as simple as, okay, going to a wedding and not talking to anybody. Okay, what if they ask me this? What if they judge me on my dress? What if they ask me about my marriage? What if they ask me about my career? That kind of public scrutiny. And it can be as simple as not being able to sit with your friends and having food because of fear of scrutiny there. What if they judge me on how I eat? What if they judge me on what I've brought for food? And it could be even debilitating, like going in a public transport where it is crowded and not able to ask the conductor for ticket. So I've had a patient who who did not stay in Chennai for looking for a job, who came back to Tanjavur, because in Chennai she had to use public transport for everything, and every time she wants to ask a ticket, it was so much difficult for her. There was another patient who was not able to go to a grocery store and ask for a pack of sugar or a pack of salt. So asking them is having a lot of anxiety. So that is social situations, and there is a fear. So it's mostly the fear of embarrassment is what is seen in social anxiety. One of the specifier in social anxiety is performance anxiety. So like I all in the beginning I told you, whenever there is a performance like an exam or a stage, everywhere everybody will have some more sort of anxiety. But there in 10 people who are going to perform, one person will be having extreme fear. Sometimes they will vomit, sometimes they will have diarrhea, sometimes they will just have a syncopal attack and fall. That kind of extreme fear is called as performance anxiety. And because of that, sometimes they will just right. So, some stage fear is not agoraphobia. Stage fear is performance anxiety. Okay. Stage fear is you are having a perform anxiety related to how you are going to perform. That is performance anxiety, right? Oh, Dr. Soundarian, I'm so sorry about that. But anyway, so this is what will happen when you are and when there is a performance anxiety, and that particular person will put leave. Okay, they will be prepared and everything. The drama will be a very important key component will be that particular person. They will just put leave and go away. So that much of anxiety will be there, and an anxiety makes you do a lot of things, and that will or one of that will also be avoidance. Okay, now coming to specific phobia. So there is a strong irrational fear of an object or a situation. So these are all named specific phobia. Only in that situation or that particular object exposure you are going to have fear. So there is ailuro, there is cynophobia, that is fear of cats, fear of dogs, acrophobia, fear of heights, algophobia, fear of pain, claustrophobia, fear of closed spaces, mesophobia, fear of germs, dust, xenophobia, fear of strangers, nyctophobia, fear of darkness or night time, zoophobia, fear of animals. In this, xenophobia was a previously asked question. Nyctophobia was a previously asked question. For this closed spaces, you have to be very cautious if it is claustrophobia or if it is a part of a cluster of symptoms that is here, agoraphobia. So you have to be cautious about the. Now, there are other phobias that can also be asked. So this is just example. So if you see some other phobias, just add it here. Okay. So for these situational anxiety, what is the treatment? Okay, the treatment is again here we can use behavior therapy. That is correct the avoidance. This can be one treatment. The preferred treatment is one subtype of CBT that is called as systematic desensitization, which is also called as graded exposure. This is gradedly it is done, and sometimes it might be done all together, that is flooding or implosion. So the treatment is SSRI plus or minus benzodiazepine, and If it is a specific situation, like for example, I have a fear of night and I have to go out at night, or I have a fear or specific social phobia, performance anxiety, and I have to go on stage today, then for situation specific, then I can use propranolol, right? Selective mutism, if you've seen this Big Bang Theory series, and there is a character called Raj, that is specifically what selective mutism is all about. It is, I'm not saying he's having selective mutism, but you can understand the concept. There is a failure to speak in specific social situations when there is an expectation for speaking. It's usually seen in children where they will be talking a lot at home and they will not even open their mouth at school. So that is selective mutism. It's because of anxiety. Separation anxiety, that is developmentally inappropriate. So 1 year or 2 year old is going to have anxiety when it is separated from its attachment figure, that is the mother or the grandmother or the primary caregiver. Whereas if it is developmentally inappropriate, a 10-year-old child feeling so much of fear and anxiety for separating from the mother or something, then it is called a separation anxiety disorder. In substance induced anxiety like symptoms can be seen in stimulants, cocaine, right, heart rate increases, arrhythmias, etc. In alcohol withdrawal also, they can look like it is a anxiety. And then cannabis, when they have a bad trip, it looks like a panic attack. We studied that yesterday, remember? Right. What are the medical conditions associated with anxiety? Again, hyperthyroidism, they will have increased sleeping heart rate and they will look like they have anxiety symptoms. Pheochromocytoma, we already discussed, right? Also in certain carcinoid syndrome where there is increased norepinephrine, carcinoid syndrome. And even when there is a hypertension, sometimes patients will have it works both way. Anxiety can cause, persistent anxiety can cause hypertension patients can also cause anxiety. Now the last one, when there is anxiety all the time everywhere, that is generalized anxiety disorder, right? Excessive anxiety and worry about several events or activities for most days, period of 6 months. It is associated with muscle tension, irritability, difficulty speaking, and restlessness. It is all associated with somatic symptoms. So this is where that INI-CET question was framed. I told you, right? Tingling of extremities was given. So somatic symptoms can be any bodily symptoms, right? So for this, there is persistent, free floating anxiety, and there is worry about future. What if this happens? So if you're having a break day and you are chilling out, the patient with anxiety will be, what if tomorrow something bad happens, or what if we meet with an accident, or what if a patient comes with an MI, oh my god, why are we chilling, we should be prepared for it, etc. Right? So pharmacotherapy, again, for all anxiety disorders, SSRI is a preferred drug, right? SSRIs. Psychotherapy, again, for everything it is CBT is the preferred psychotherapy. Okay, right. So try answering the questions. I'll give you a couple of minutes and then we'll discuss. So shall we discuss the questions? Irrational fear of spiders. So this is a case of specific phobia. The name of this could be, I think, arachnidophobia. Treatment of choice, like I told you, for all these phobia and everything, the treatment of choice is actually therapy. So here it is exposure response prevention. Now you might ask me, it was given systematic desensitization. So all of this are actually similar. Exposure response prevention and systematic desensitization are actually similar. Okay, so if this is the option, then you can choose this. Medical student complains of feeling anxious, palpitations, chest tightness, choking sensation, breathlessness, fear of impending doom. So this was a question on May 2022 NEET. Okay, so investigations, examination finding, ECG was all normal. So this is a case of panic attack. Fear of closed spaces is called as So can you write this fear of closed spaces is also a place where you cannot escape. So can you write agoraphobia for this? Right. The answer is claustrophobia. Thank you, Dr. Karan. But why not agoraphobia? Yes, so it has to be two or more situations from the given five. That is closed spaces, public transportation, open spaces, standing in a line, or in a or alone at home. Right. Which of the following is the most commonly associated with agoraphobia? We already discussed this. Panic disorder. All of the following are seen in anxiety except, right. So there is hyperventilation, there is cold extremities, there is palpitation, and there is only hyperhidrosis, increased sweating. Hence, this is the answer. All of the following are seen in generalized anxiety disorder except. So muscle tension is seen. Yes. Irritability, restlessness. Yes. This feeling of impending doom, it is occurring only in a panic attack. Right. So in generalized anxiety patients, if there is a panic attack, then this will come. But in general, it will not be there. 40-year-old has come with history of nervousness, feeling tensed, having gastrointestinal symptoms. So this was the question that was asked in INI-CET May 2024. This is the exact question. So they have given a history of generalized anxiety disorder, and they have asked what additional symptom. So this ideas of reference is a psychotic symptom. Neologism is a psychotic symptom. Hallucination is a psychotic symptom. So these cannot come in an anxiety spectrum, because psychotic symptoms means the spectrum itself changes, psychotic spectrum. Right? It cannot come. In mood disorders, it can be associated with psychotic symptoms, whereas anxiety disorders are neurotic spectrum. So the answer is tingling of extremities. Thank you. Panic attack is associated with a disturbance in all of the neurotransmitters except. So, if you look at the first page, this will be dopamine, CCK, all of this will be there, this will be there, this will be there. Glutamate is the only neurotransmitter which is not associated with panic attack. True of social phobia is irrational fear of not specified objects, not activities, not closed space. It is fear of situation, especially social situation, right? 35-year-old male is brought with history of fear of leaving home, fear of traveling alone, and fear of being in a crowd. He develops, so there is fear of leaving home, 1, fear of traveling alone, 2, fear of being in a crowd, 3. So there is more than 2 situations. Marked anxiety and sweating if he is in this situation. So there is a panic attack associates also. Hence he is avoiding public transport to go to office. So this is a case of agoraphobia, right? This is how you have to answer questions, right?